I'm Kimia Banger, a mom of a 5-year-old boy with Alport Syndrome. It's so inspiring for me to see so many people today, here and online. Last month, ASF's virtual Alport Connect 2022 patient meeting began with a video featuring a group of Alport patients sharing a bit about their achievements and victories over the past year. As a parent, it's very helpful for me to hear positive experiences from patients living with Alport Syndrome. This gives me hope that my son will also become educated about his disease, not let it define who he is and what he is able to accomplish. I'm grateful that people in the video were willing to share the milestones in their lives this year, and I hope you all find it hopeful as well.
Have X-linked Alport syndrome.
My diagnosis has never been confirmed since I was 9.
I was diagnosed with X-linked Alport syndrome when I was 14 years old.
I was diagnosed with Alport syndrome when I was 4.
Our boys were diagnosed with Alport syndrome 15 years ago when they were in grade school.
And I was diagnosed with Alport syndrome in my late 20s.
My Alport syndrome journey started when I was really young. I was 6 years old at the time. My brother was 7 when we were diagnosed, and my mother was diagnosed with us at the same time.
Myself and my oldest son were diagnosed with Alport syndrome just over a year ago.
In my mid-30s, my kidney function declined rapidly and my health deteriorated. I was fortunate enough to receive a kidney from a dear friend of mine on June 1st of this year. So to all the women out there, I'd just like to say, please advocate for yourselves. We're not just carriers. It's very important for you to be followed by a nephrologist to make sure that you're preserving your kidney function.
I'm still very hopeful because my symptoms have been quite stable, and I'm really looking forward to my senior year in college. Last year, I got a job working in a research lab that I'm interested in, and this year I got approved to pursue a thesis in the same project. I really appreciated it, and I'm really excited about it.
This year, on May 6th, I received a kidney transplant, and I'm even more fortunate that things are going successfully so far. I'm actually really optimistic about the future of treatment and research into Alport syndrome. I think a lot of that is driven by the Alport Syndrome Foundation and its advocacy.
I'm one of the Paul Silver Enrichment Award recipients. My goal is to one day become a genetic counselor, and this award is going to help me tremendously with my graduate school application fees. My desire to be a genetic counselor all started with my journey through Alports, and I'm really looking forward and really hopeful moving into this field of genetics as it's a huge part of the future of medicine.
I am now 23 and I'm 3 years post-kidney transplant. I'm also 50% deaf in each ear and I wear hearing aids. In the last year, my biggest wins have definitely been graduating from college with my bachelor's in nursing, passing my NCLEX and obtaining my RN license, and securing a job on the transplant unit where I was a patient 3 years ago.
Unfortunately, around a year ago, our youngest son's kidneys started to decline more rapidly.
At that time, I was evaluated to be a living donor for Brett. That process went pretty quickly. We are now about 6 months post-op. The procedure went great. Everything was according to plan. At this point in time, Brett's back in school, living in his off-campus apartment with his roommates, and I'm back at work, and everything's good.
At the time, it was a really overwhelming diagnosis, and it brought on a lot of fear and anxiety. But I decided at that moment, when I felt like I was handed lemons, that I was going to go ahead and make lemonade. So instead of having all those fears and the what-ifs, I decided to have more of an I can mentality.
I was fortunate to get a transplant. I'm going on almost 30 years. My mom has Alport syndrome. My 2 older brothers and other family members.
It was really tough for us, but I had great pediatric nephrologists that helped to inspire me to go into medicine. And in the last year, I have finished my 3rd year of medical school, done really well on my board exams, and I'm applying currently for the match. And I'm hopeful that I get to help people just the same way that my pediatric nephrologist helped me.
I'm optimistic for the future, and so that when my daughter gets to be my age, things will be different for her.
I really enjoy connecting with other transplant and dialysis patients, and connecting with other teens and young adults with Alport Syndrome, and that's what really keeps me going and gives me hope for the future.
I hope that if you've recently been diagnosed or have been down this journey for a while, you know that you're loved and supported, and you have me and so many of the Alport Syndrome community cheering you on. We're in your corner. We got this.
Thanks for that. Sorry. Well, thanks for that wonderful video. And so perhaps a little bit related is that I just want to say that I'm happy to be here as part of this meeting today as an adult nephrologist. And I was just talking over the break with Neil Turner, and we were commenting that it's really nice to see that there's kind of a little bit of a resurgence in interest in Alport syndrome and developing therapeutics in the area. And there aren't many adult nephrologists, for instance, that have interest in Alport syndrome. And I know through my own clinical training in adult nephrology, I didn't hear much about Alport syndrome. But it was really through my interest in genetics that I realized that there was a not insignificant number of adult patients with Alport syndrome that weren't diagnosed. And that really launched my own interest in Alport syndrome. So, as I said, I'm happy to be here today. And with that, I will say that I'll introduce the next session, which will be co-moderated by two children kidney doctors. Again, Dr. Michelle Rowe, who's here in person, and Dr. Rachel Lennon, who's with us online. The focus of this presentation is diagnosis, and we have two speakers. The first is Professor Rosa Tora, who's an adult kidney doctor from Barcelona, Spain, followed by Professor Denitzia. I'm going to call her Professor Denitzia because I don't want to mispronounce her last name, from the Department of Pathology, University of Zagreb School of Medicine, and is the head of the Department of Nephropathology and Electron Microscopy in Zagreb, Croatia. So over to you, Rosa, to start. I believe she's online. Rosa, are you there?
No, sorry. Can you hear me?
Yes, we can hear you.
Well, thanks for the introduction. As she said, my name is Rosa Tora. I'm an adult nephrologist working in Barcelona and very interested for my whole professional life in inherited kidney diseases. These are my disclosures. I'm a member of the Council of the ERA. And I will share with you some thoughts, and many has been already said. We know what's going on in Alport syndrome. We know there's an abnormality in collagen 4 in these protomers coded by focal 43, 4, and 5. We also know, next, let me, okay. We should wait for putting next. It doesn't advance. Does not advance. Yeah, I do, but it says wait because the remote control asks you to wait. Okay, I don't see that. I don't know where I am.
I'm sorry, say it again? Oh, she left the session. Okay. 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 So why don't we go to the video? Then the next person is a video. Is it? Yeah. Yeah. Okay. So Janitzia. Okay. And hers is FSGS as part of an Alport spectrum disorder. Is that correct? I think that's right. Yeah. Okay. So you can play the video.
Good afternoon. Thank you, the organizer, for their kind invitation. Focal segmental glomerulosclerosis, or FSGS, is the morphological term which describes changes which are in glomeruli, which are focal, involve less than 50% of total glomeruli, segmental, involve just a part of single glomerulus, and characteristically lesions are sclerotic, which means increased extracellular collagen matrix with obliteration of the capillary lumina. These changes is very often. According to our kidney biopsy registry, FSGS is on the second place immediately after IgA nephropathy. However, there are several different reasons to have focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis could be primary, secondary, or genetic. The cause of primary FSGS is unknown. There is some circulating podocytotoxic factor which causes severe nephrotic syndrome, and immunosuppressive therapy is usually effective. Secondary focal segmental glomerulosclerosis could be maladaptive due to viral infection, drug-induced, or it could be just glomerular scarring due to different glomerular diseases, including IgA nephropathy and Alport spectrum. Very often, maybe the most often, secondary type of FSGS is maladaptive changes due to increase in glomerular blood pressure, usually with signal clinically in obese patient or patient with very low birth weight. Today, there are more than 40 different genes which can cause genetic FSGS. Most prominent are nephrin and podocin, but today we know that a type 4 collagen mutation can be also cause of genetic FSGS, especially in adults. There are 5 morphological types of FSGS. The most often is NOS, not otherwise specified, which is characterized only by segmental sclerosis and can be found in all mentioned pathogenetical type of FSGS. The second is perihilar, which is usually secondary due to maladaptation. Tip variant is characterized with small segmental sclerosis near urinary pole. Cellular variant actually is characterized with endocapillary hypercellularity rather than sclerosis. It's rare and it's usually primary FSGS, and the most severe disease is collapsing FSGS, characterized with glomerular capillary collapse and podocyte hyperplasia. It could be primary or secondary, for example, due to HIV infection. Electron microscopy in FSGS is very important because in primary FSGS there is diffuse food process effacement, and in secondary this effacement is only focal. It is very known for a long time that classical Alport syndrome has a focal segmental sclerosis, especially in advanced disease. Early in the age, glomeruli are usually normal. Later, there is small segmental sclerosis, usually perihilar. And in advanced disease, there is severe segmental sclerosis. Electron microscopy in this situation is very helpful because there are characteristical GBM changes consistent with Alport syndrome, and food process effacement is usually focal. So it is very important to perform electron microscopy for every native kidney biopsy, especially with FSGS, because it can help to differentiate primary versus secondary FSGS, and if there is GBM changes, there is suspicion for Alport syndrome. FSGS is not only part of classical Alport syndrome, but also thin basement membrane nephropathy. This was first described by Professor Deltas. He recognized with his group that heterozygous patient with thin basement membrane can progress, and a lot of them, this patient have focal segmental glomerulosclerosis. We have the same experience in our cohort of heterozygous alpha-3 or alpha-4 patient. Focal segmental glomerulosclerosis was present in 25% of them. So for sure we know today that focal segmental glomerulosclerosis, among others, it's risk factor for progression of thin basement membrane nephropathy. There are more and more data that type 4 collagen mutation are the most frequent cause of adult focal segmental glomerulosclerosis. Usually on electron microscopy, the changes of GBM are present, but there are some patients in which there was no glomerular basement membrane changes, but just food process effacement and focal segmental sclerosis on light microscopy. This was very well shown in this last recently published manuscript, where all patients with collagen 4 mutation and FSGS have food process effacement, but only 56 have glomerular basement membrane changes. In conclusion, diagnosis of FSGS can be challenged, and for all this biopsy, we should perform not only immunofluorescence but also electron microscopy, and if there is a glomerular basement membrane changes, or patient have positive family history, or FSGS resistant to therapy, genetic testing should be performed. And we should always keep in mind that a patient can have two diseases, Alport spectrum disorders and primary focal segmental glomerulosclerosis, and in that situation, electron microscopy with finding of diffuse food process effacement can help. Thank you for your attention, and I would like to invite you on the 5th International Renal Pathology Conference, which will be next year in Zagreb.
Thank you, Dr. Denizia. So do we have Dr. Torab back with us?
Yes.
Okay. Sorry for the technical difficulties. Perhaps we could maybe start, is it advisable to start from the beginning? Yeah, okay. So we'll just start, if it's okay, Roser, to just start from the beginning.
Okay, apologies. After 2 years of virtual life, we still have trouble. Sorry about this. So, okay, next. These are my disclosures. I'm council member of the ERA. And we know what's going on in Alport syndrome. We know the abnormal proteins, the abnormal protomers that we have, the genes causing it, 43, 4, and 5 already. All this has already been mentioned. We know it is a frequent disease. How frequent? Thanks to this wonderful work by the Group of Columbia, led by Ali Karabi, they analyzed more than 3,000 patients with chronic kidney disease, mostly of them adults, 5% from non-European ancestry, and found monogenic renal disease in 9.3% of them. And if we break it down, we can see that ADPKD accounted for 31%, but collagen 4 for 30%. So very close to ADPKD. And if we look closer, we see that COL4A5 accounted for 14% and 16% COL4A3 and 4. If we include here the recessive forms for COL3 and 4, we see, and we know from the recent data from the UK Biobank that COL4A3 and 4 is 20-fold more frequent than COL4A5. But here we see that COL4A4 and 5 are almost as frequent as a cause of chronic kidney disease. We can conclude that COL4A3 and 4 are 20-fold less likely to cause chronic kidney disease. And this has very nicely been shown by Judy Savage very recently in KI reports. And not only this, but if we consider that heterozygous carriers of COL4A3 and 4 may only have micromaturia or even nothing, and probably or for sure, Alport, or however we call this, we need to agree on that, is probably the most frequent genetic kidney condition. But we still have a lot of trouble diagnosing it, right? We know it is not correctly diagnosed. From this study, from the Columbia one, we've seen that a very large amount of patients, the largest percentage, did not have a proper diagnosis. Only 35% of them did. And most of them had the diagnosis of a glomerular disease, whatever it was. And why is that? We have many reasons for that, but the pattern of inheritance is very important. You all know there are 3 patterns of inheritance. We need still to agree on the autosomal dominant form, right? But of course, the risk of end-stage kidney disease varies a lot, and the prevalence too. And the second one is wrong. Sorry about this. The autosomal dominant is 1 in 106, according to the recent data from the UK Biobank. So we have these very different types of Alport syndrome, right? Very different behaviors. We know it has a very wide spectrum. These extrarenal features are very frequently found in autosomal recessive and males with X-linked Alport syndrome, but not frequently in females and very rare, extremely rare in the autosomal dominant form. And we have many reasons for this. Mosaicism can explain that. The genetic background, including modifying genes, diagenic inheritance, hypomorphic alleles, different genes causing different phenotypes, different mutations causing different severity of the disease, incomplete penetrance, splicing mutations, epigenetic regulation for sure has a lot to do, but we don't know much about it, environmental factors, and of course, X inactivation for the X-linked form. But then, when should we suspect it? We've seen there are many types, a wide spectrum of disease. It was not the case when it was first reported by Dr. Alport. In 1924, he saw a 14-year-old boy with hematuria, and when he reviewed his family history, he found that almost all the affected boys in 3 generations had hematuria, nephritis, and deafness. Then he published it in the British Medical Journal, and physicians called that disease hereditary familial congenital hemorrhagic nephritis. And this was accompanied by eye and ear involvement. So for many, many years, Alport syndrome has only been suspected when there was eye or especially ear involvement, a hematuria, proteinuria, and chronic kidney disease. But this has changed, and you know why? Because we have NGS or genetic testing for a few years now. So we need to properly use the tools we have nowadays. But the first step towards diagnosing Alport syndrome is to suspect it and then to confirm that suspicion using genetic testing or kidney biopsy. And when should we suspect it? We've heard a lot about it. But for sure, when there is a family history of microhematuria or chronic kidney disease, you must think of it. They may show the typical features, these ones described by Dr. Alport, but they may not. They may just show hematuria that we learned from Laura very nicely, that it may decrease a long time. So they may even not have microhematuria. They may have chronic kidney disease. So think of it in a family with chronic kidney disease. Then when a patient has extrarenal features, of course you'll think of it. These are the easiest ones, right? First and second. Then the third one is also quite easy. FSGS, when we know it is a pathological term, it's been said already. I was quite concerned when I've heard differential diagnosis of Alport syndrome with FSGS. Well, as the pathologist has shown us, it is a pathological finding, like thin basement membrane disease. It's not a disease itself, right? It's a pathological finding. And we've known for many years that the advanced stages of Alport syndrome presents as FSGS in the kidney biopsy. But when the FSGS in a patient, usually in an adult, he has hematuria, not always, as Laura shown, but especially in absence of an immune or secondary cause of FSGS, let's say obesity, or when you give immunosuppressors and then the nephrotic syndrome disappears. But usually nephrotic range proteinuria is not there, maybe, but it's not usual. Then you think of Alport syndrome and ask for genetic testing. And the most problematic setting, I would say, a patient with hematuria with or without proteinuria, usually in absence of nephrotic syndrome. What to say? I suggest to consider genetic testing if the disease is stable, but probably in children. In children, the most frequent differential diagnosis is IgA nephropathy, right? But in adults, we have so many glomerulopathies that may cause this, that probably we go for kidney biopsy. But in any case, if the suspicion of Alport syndrome is low, at least in adults, we always consider kidney biopsy because of this. The chances of being Alport syndrome are low. In kids, I'm not that sure. And why? Why is that? Well, because a kidney biopsy is not, it is a risky procedure. Usually nothing happens. We agree on that. But there may be some trouble. Pain, hematomas, macroscopic hematuria, need for transfusion, and even intervention, embolization, nephrectomy. Fortunately, this is very infrequent, but it implies admission into the hospital, and well, it's quite a big deal. It may allow precise diagnosis if it is not Alport syndrome. So this is a good thing, and especially for in this, I've told you, these adults with a proteinuric disease, with hematuria, many of them do not have Alport syndrome. So with a kidney biopsy, we end up with a diagnosis. But opposite to that, even being Alport syndrome, kidney biopsy does not always allow us a definite diagnosis. It may say it's suspected Alport syndrome, there's an abnormality in the thin basement membrane, in the basement membrane, but they cannot tell for sure it is Alport syndrome. And do not forget that, because we think that genetic testing is very expensive, but an kidney biopsy is much more expensive. And what about the genetic testing? It is a risk-free procedure, of course, it's a blood extraction, nothing. It gives you a definite diagnosis, and it's the only test allowing you to diagnose heterozygous COL4A3 and 4 carriers. It's very difficult that a pathologist with a renal biopsy can reassure you it is that disease. In case of not being Alport syndrome, it gives no clues on the diagnosis of nephropathy because it's probably an immune glomerulopathy, not a genetic one. So it gives no clues, opposite to kidney biopsy that allows you to have another diagnosis. And the chances of the genetic testing being negative are very high in absence of a high suspicion. I guess that the cheaper and the more accessible genetic testing will be, the more it will replace kidney biopsy at first stage when the patient remains stable. Of course, not in a flare of nephrotic syndrome. We won't wait, but probably for this low degree of proteinuria, very stable with hematuria and so on. Well, these are my personal opinions, of course. And finally, I thank all the Alport guys. This picture was taken in Siena before COVID. I have very good memories of that meeting. And that's all. Thank you for your attention. Apologies for the technical travels, and I'd be glad to take any questions.
All right, thanks to both for those interesting talks. And I'm trying to find the questions online. Does anybody have any in-person questions they'd like to ask today? And while you're thinking about it, Dr. Lennon, you had a question in the chat. Why don't I let you ask that one
Sure.
in person?
Yeah. Hi, everybody. Yes. So this was for Danica. Thank you for your presentation. And I would be interested on your views of the proportion of native kidney biopsies for a primary glomerular disorder that, in reality, although we may have the intention of having electron microscopy, do we have an idea of how many in reality actually get EM? I know that's not 100% in the UK. Oh, have we got Danica available? Maybe not.
Yeah, now
yes.
Okay. I should wait to technician people. So it depends. You know, it's in the United States, according information, there is almost 100% native kidney biopsy have electron microscopy. In Europe, it's quite different. The range is between 20 to 70%. So it just depends about availability. In my country, still electron microscopy is cheaper than genetic testing. So that's the reason why we do electron microscopy for all native kidney biopsy. So it really depends about availability of electron microscopy. And that's the only reason. So, and I agree, I'll never say now that it's Alport syndrome according to morphology, but I can suspicion that. And then I have actually a question for Rosa. Rosa, how we can make differential diagnosis between IgA nephropathy and Alport syndrome, not in young children, but in children between 10 and 20 years. No. Very often they have IgA nephropathy. and the question is how long to wait, you know? That's I completely agree with you. If it's young children without any symptoms, that's no problem. But even children or young boy between 10 and 20 years, according to my experience, they often have beginning of IgA nephropathy, which is also slow progression disease. That's
I'm not a pediatric nephrologist, but my reasoning is that I still think it's more expensive because you only said electron microscopy, but the kid has to be admitted into the hospital, bed, nurses, doctors, everything. So it's not only the microscope, it's everything. In an ideal world, I think, why not? Why don't you ask for genetic testing? And if it's negative, go ahead and perform a kidney biopsy.
Sure.
This would be an ideal world, and to avoid kidney biopsy in a significant percentage of kids.
Sure.
I don't know. I'm not a pediatric nephrologist again.
There are some pediatricians. So I agree with you. If we have possibility to do genetic tests, especially for young children, for me it's the best. Sometimes even I tell my clinicians, please don't repeat biopsy. Try do genetic, because very often I saw thin basement membrane, and I said just thin basement membrane, and they say, oh, we will repeat biopsy in the next 2 or 3 years again, and I think it's not useful. So that's.
As a pediatric nephrologist, I can tell you that recommending a kidney biopsy can be a tough sell for families. Even though you tell them, I do this 100 times a year, kids do well. We really learn a lot from the kidney biopsy. It can be a challenge to get that done. But Dr. Barua, you have a question for us today?
So thanks for the talks. I had a comment and a question. I think that, so Rachel mentioned one of our papers, which was a genome-wide association study of hematuria in the UK Biobank. And I think that IgA nephropathy is an important part of the differential diagnosis for hematuria. The strongest association that we found was in the type 4 collagen genes, but that was followed by an association in the MHC locus, which is implicated in IgA. But my question is for Rosa, which is, as an adult nephrologist, I think I might see this a bit more than pediatric nephrologists, is that often I will get patients who have glomerular basement membrane abnormalities on their renal biopsy, hematuria, but their Alport syndrome testing is negative. So what do you think is going on in those patients? How do you handle those patients?
Yeah, I do have those, but also patients with even hearing loss and negative genetic testing. Of course, very few of them. Well, we know genetic testing is not 100% sensitive, right? I just follow them up, and I consider them as being Alport syndrome patients. To be honest, this is what I do.
Yeah, me too. All right, Dr. Turner.
Thanks. It's a fascinating and really important discussion. As adult nephrologists, we're being urged by some people to avoid doing kidney biopsies in other contexts where not necessarily genetic tests, but antibody tests for membranous nephropathy, for instance, have come along. I think we're just beginning to see the mistakes that we'll make if we adopt this policy too early. I think if you do a genetic test and you find a severe mutation likely to cause end-stage kidney disease in a young patient, and the clinical features fit, then you don't need to do a biopsy. But if you find only a mutation in one of 2 copies, we don't know what it is that makes some patients do badly and some well, and we're going to find that some of these patients have a second diagnosis, for which there may be different treatments, which may be important in the long run. And this is an area which we discussed earlier. We really don't understand. It's great to hear biopsies being spoken highly of, and we stop doing them at great risk, I think. Yeah, that's probably more comment than question, but it's a really important cautionary tale.
Right, and I think Dr. Tora has a response.
Well, not a response. It's also a comment more or less related to this. When I said kids, it's because I think it's really a huge difference. We know how frequent are heterozygous mutations in COL4A3 and 4. So think, for example, of a patient with a glomerulopathy, and we perform a genetic test, and we found a mutation in one of those genes. And we think, okay, no need for kidney biopsy, but the patient may have another glomerulopathy. Someone with a glomerulopathy has 1 in 100 chances of having a mutation in one of these genes. So this is why in adults, I'm not that convinced that it can replace it. only when you have a high suspicion, extrarenal features, of course, strong family history. But otherwise, I agree with Neil that kidney biopsy has a strong role.
So we have a question online from Dr. Deltas. So you've gone ahead and you've done your kidney biopsy. You see thinning, thickening, and lamellation on the electron microscopy. What is your differential diagnosis? What other conditions might be present in that situation? And any of our speakers can tackle that one.
Okay, I can just say it could be another genetical diseases with the GBM morphology. For example, just a week ago, it was thin basement membrane with focal lamellation, and it was nail patella syndrome. So there are some other syndromes, and I think that on the level of morphology we can suspect Alport, and after that other mutation which involves glomerular basement structure. So that's it. So on the level of morphology, I can only say that. That's the reason why I never sign it's Alport syndrome. I always sign my report is consistent mostly with Alport, genetic testing is suggested. So because morphology is not really 100% specific, and as you mentioned, type 4 collagen mutations are most often mutations, so we see that most often. But I told you just a week before I was sure thin basement membrane with focal lamination, but was nail patella syndrome. So.
And Dr. Lennon, did you want to comment? I see you have a comment here in the chat.
Yes, I just added. So yeah, so that's the kind of what it looks like morphologically. I guess the genes that we know about so far. So for LMX1B with nail patella, and then MYH9, which causes this very similar phenotype in the kidney. Also hearing loss. It's got various eponymous names: Epstein syndrome, Fechner syndrome. And the clue there, which I think Michelle tweeted about just this very week, is the low platelet count. So you get macro thrombocytopenia.
All right, so we have time for one more question from Dr. Miner, and I'm curious to hear what he has to say because kidney biopsies in mice are very challenging. You have to kill the mouse and take the whole kidney out. So.
Yes, that would change our life if we could biopsy the kidneys. So I was going to ask why there's no more mention of skin biopsies for suspected X-linked Alport syndrome.
I'll let either of our speakers comment on that one.
Can I comment?
You may.
Skin biopsies are talked about quite a lot, but the technique is actually very challenging and not very reliable unless someone is doing a lot of it. That's my experience. And the other thing is that you're only altogether missing the 5-6 network in skin if you have a complete deletion of the gene. And you know, these are the patients in whom the diagnosis is often most obvious clinically, and they fall out on genetic testing very quickly. So it may rarely be useful still, but I think it's probably something mostly of historical and animal experiment interest.
Agree.
Yeah, agree also.
All right. Well, thank you both, and to my co-moderators for that great session. We're very much appreciative, and diagnosis is such an important part of what we do. So next, we're going to switch gears a little bit, and we're going to start talking about hearing. Now, I'm a pediatric kidney doctor. I should have no business being up here talking to you about hearing. But it turns out that it's really important for what I do, because if I'm not recommending hearing screening to my patients with Alport syndrome, they're not really hearing that recommendation or they're not getting that recommendation from others because their general pediatrician may not know what the risk is. So what I am pleased to introduce Dr. Stamatia Staikoudi, who's an audiologist currently running her own private practice in Greece. and she worked for the NHS Scotland in Edinburgh for 12 years, 7 of which as a senior audiologist. And there she looked after many patients with renal syndromes and hearing loss, the vast majority of which had Alport syndrome. And I'm happy to note that she had lost her audio on the chat over time and now has gotten it back. So we actually will have her here. So Stamatia, off to you.
Thank you. Good morning, good evening from Greece. I'm delighted to be with you today and talk to you about hearing loss in Alport syndrome. As you know, Alport syndrome is characterized by kidney problems, and hearing loss is an associated problem in patients with Alport syndrome, but it is very relevant because more often than not, it is one of the very first signs of the syndrome, and it can also offer us a glimpse with regards to the prognosis of the kidney problems. So, hearing loss can be one of the very first signs in Alport syndrome. The problem is within the cochlea, which is the organ of hearing. We've got one of each behind these bones here. So typically the hearing loss is sensory neural, which means that the problem is in the cochlea, in the organ of hearing, and it will affect both ears. It will vary in severity. It can be mild or moderate or severe. And it mainly affects medium and high tone pitches, and it is usually symmetrical. I have never seen an asymmetrical hearing loss in an Alport syndrome patient. It's more or less the same level of damage in both ears. Speech perception is basically what the audiogram indicates for patients with Alport syndrome and hearing loss. And these patients often have sensitivity in certain loud sounds, especially in middle frequencies and middle tone pitches. We don't know what that is yet. It has not been investigated, but this is something that I have noticed as well, and it requires special programming in the hearing aids to make these sounds tolerable to the patients until the brain learns to deal with them. The auditory nerves and the higher auditory centers are fine in Alport syndrome patients. So the problem, hearing-wise, is peripheral in Alport syndrome patients. We don't know exactly that is. We presume that this is something to do with when the ear is formed, because the ear and the kidney are formed from the same crest. They are quite similar in size, in shape as well. Just to give you a better idea of what I'm talking about, here's a bit of an anatomy. The outer ear is the bit that we can all see, and the ear canal is a small hole in our ears. This is where wax is produced, and as we go further in, we end up on the eardrum, which is a very thin layer of skin that accepts all the air waves from the environment. So as soon as the sounds, the air waves hit the eardrum starts moving and sets the middle ear bones in action. So these sound waves are then turned into mechanical energy within the middle ear. That last bone looks like a foot plate there, and that starts passing on the mechanical energy to the cochlea. Now, cochlea is Greek for snail, because it looks like a snail. And so this snail is the organ of hearing, and it is connected with the organ of balance over there. And these are the peripheral centers, the peripheral auditory centers, and the mechanical information of sound that has been passed on from the middle ear to the inner ear here is converted into electrical stimulation that ends up to the brain for processing via the 8th cranial nerve, which is a nerve with 2 functions: 1, hearing, 2, balance. So, and then the brain makes sense of what we hear. So, but how the brain makes sense of what we hear is a different story altogether. If we have a closer look within the cochlea, which is where the problem is with Alport syndrome patients, the cochlea has 3 ducts full of fluids with very specific chemical composition, but the middle one is the one that we are interested in because this is where the organ of Corti is, which is the true organ of hearing, and this is where the cells are that can be damaged in Alport syndrome patients. I've got a very closer look here for you. So it's a brilliant image, this one. So these are the cells that can be missing in patients with Alport syndrome. They are hair cells, and these are the cells that are supposed to get the sounds into electrical stimulation and get passed to the auditory nerve. These are the auditory nerve synapses here. But these things are all damaged and missing in vast areas within the cochlea of Alport syndrome patients, hence the hearing loss. I always say that any unexplained hearing loss in a child or adolescent or a young person in general, up to mid-20s, let's say, roughly speaking, should always be followed immediately by a urine test. I always tell the family that, have a urine test, see if it's clear, fine, forget about it. If it shows a bit of blood or a bit of protein, a bit too much protein, then we'll speak to a pediatric nephrologist and that's it. And everyone can have a peace of mind. So when it comes to monitoring someone with Alport syndrome and hearing loss, it depends on their age. Children up to the age of 11, we need to monitor them closely every 6 months, have repeat hearing assessments, just to be on the safe side, because it will take a while for the child to tell you that I can't hear well, that they're struggling to hear, that they've lost part of their hearing. Children over 11, depending on how mature they are, how much you can trust them, we can keep them on an annual reassessment rate. Adolescents are always, teenagers are always tricky. It depends on the patient. Some of them hate the fact that they have hearing loss because they've got the kidney issues going on and lots of things, they're on medication and they cannot have a normal life. So hearing loss is the last thing they wanted to have on top of everything else. So sometimes parents have to drag them in the clinic. Usually we get on well. I mean, in the last 3 to 5 years, hearing aid technology has evolved quite a bit, and children are fine with hearing aids. They're very familiar with wearable technology, so they don't mind wearing something on their ears or, generally speaking, on their body, and they don't get bullied about wearable technology anymore because everybody loves wearable technology these days, and everybody loves being different these days. It's very trendy. So it is becoming a bit easier for people like me to help people with hearing loss, especially younger people with hearing loss. So we need to have a very careful follow-up of the hearing loss and careful monitoring, because it can be a predictor of the prognosis of kidney problems. And we need to use hearing aids as early as possible, and also make sure that patients who have visual problems on top of hearing problems, that have these hearing problems addressed to and solved very early or as early as possible, because vision assists hearing by 50%. So if you cannot see perfect, then it will affect on how you hear as a result. It is very important to intervene early in patients with hearing loss. All sorts of things can go wrong, and I've put them in a slide over there. It all comes down to the age of the patient. It depends on whether the hearing loss is prelingual, that is before 4.5 years of age, or postlingual. The best auditory neuroplasticity is up to 4.5 years of age, and this is where 95% of the work is done when it comes to speech acquisition and speech development. But the higher auditory centers within the brain develop up until year 16. So loads of things going on. And the thing is, when you have hearing loss, because the brain does not get proper signals from the peripheral centers, from the ears, you get atrophy. It depends. If you have developed speech and you've got your neuronal network for the higher auditory centers ready and fully developed, then if you start losing your hearing, the brain will start to shut down certain neurons that do not get any information from the ears anymore. And that in the long run, if the hearing loss is not treated, it will create atrophy, which will in turn create problems with speech perception, especially in noisy environments, let's say a classroom, a university, theater, going out with your friends, socializing. And it will cause problems with social skills because you need the higher auditory centers to develop first, and then in turn you've got the speech higher centers developing social skills, balance, you name it. So it's not just about hearing. And the thing is, when you have hearing loss, because the brain adapts to it, shuts down the centers, the neurons that don't get any signals, and moves all the action to the higher auditory centers that still get some stimulation from the ears, from the peripheral centers. Once you wear hearing aids and you hear everything normal again, it sounds different because you're used to hearing the deafened version of reality. And all hearing aid users need some time to acclimatize to hearing aids, basically to allow the brain to open up these neurons that have been closed for quite some time. Children that do not get hearing aids early have lower academic performance, and their IQ development is not as best as it would be if they heard properly or if they had early intervention with regards to their hearing loss. Even skills such as riding a bike can be a challenge for a child with hearing loss because the cochlea is not functioning properly, and therefore the organ of balance, which is connected with the cochlea, is not getting proper signals, and they're all regulated and sending signals to the brain, which has to organize everything. I've put here some types of hearing aids, just to give you a rough idea. On the left-hand side there, these are pediatric hearing aids. And here we have more adult-style hearing aids. They are both behind-the-ear hearing aids on the top, and on the bottom we've got in-the-ear hearing aids. Now, the difference between pediatric hearing aids and the rest of them is just color. They come in various colors, and they're fun for children to wear. The hardware is exactly the same in all hearing aids. The trend is to have behind-the-ear hearing aids, and basically children are not really crazy about colors. They don't care about them. It's parents who love them. It's about parents. Parents feel better. Children don't care. Children just want to hear, and they're happy with the hearing aids. They get up in the morning, they ask for their hearing aids. They like them. If we're talking about older children or teenagers, it can get a bit tricky, but the past 3 to 5 years, it's been not too bad at all. In-the-ear hearing aids come in different shapes and sizes. That comes down to the severity of hearing loss. The more severe the hearing loss, the bigger the hearing aid, because you need more hardware to support all that amplification that goes through. In-the-ear hearing aids in general last 2 years less than the behind-the-ear ones, so they're not as durable as the behind-the-ear hearing aids, because they get a lot of heat inside the ear canal and humidity and a lot of vibrations from the jaw and the ear canal walls that move as you speak and as you eat, etc., etc. So not as durable. Usually, if you get hearing aids through a voucher scheme or a national health system, you get a behind-the-ear hearing aid. And these days, they are wireless enabled. You get Bluetooth, and you can connect your mobile phone and stream your calls without holding your phone, connect them to your laptop, and listen to the music, your tablet, everything. So it's very good and very pleasant for the users. So that was all. I'll be very glad to take any questions you might have.
Thank you very much. So we have a question from the audience from Joy Toll.
Hi, you mentioned at the beginning of your presentation that you've only seen bilateral hearing loss in Alport Syndrome. My family's actually an exception to that. My sister and I both have pretty severe hearing loss on one ear, but less severe on the other. Have you found that women might be the exception to that?
So far, I've seen symmetrical hearing losses. The definition of hearing loss when it comes to Alport patient, is it Alport syndrome that you suffer from, or is it something else, a different kind of deaf renal syndrome?
I'm sorry, I gave the microphone away. We both have Alport syndrome, X-linked Alport syndrome.
It could be the X-linked factor. From my experience, even if you have asymmetrical hearing loss, at some point they will come and the 2 ears will come and meet each other. They will get the same level. It can happen. It could be an indication. I mean, it's up to, we need more research for these things, but it could be an indication of perhaps a specific kidney, like a prognosis for as a marker of the performance of the organ. It could be.
Thank you.
Has it always been like that, or has it?
Yes, my right ear declined quite rapidly, and years before I even noticed any change in my left ear has got very mild hearing loss. I wear a hearing aid in it mostly just to help my right ear figure things out.
Mm-hmm. And how have your kidneys been?
I have a GFR of 50 at the moment. But my hearing loss occurred before my kidney function started to decline. Yeah. And my sister's hearing loss occurred pretty much when she reached ESRD. And she has the opposite ear. Her left ear is the one that's particularly bad, and her right ear is fine.
Yeah. It's interesting. It's very interesting, but hearing loss in Alport syndrome has not been investigated thoroughly, if at all. Every time I give a talk, I check the latest research, and there's nothing, really. Not a lot, anyway.
Question for you next. When you see a patient who's diagnosed with Alport syndrome for their initial screening, maybe their hearing is still normal, what advice do you have for them to try to protect their hearing? Is there anything they can do, or is this really inevitable?
Well, everybody will lose their hearing sooner or later. Hearing deteriorates with age very, very slowly from the age of 30 onwards. Now, it happens before 30, but us audiologists kind of sugarcoat it for you, and we just say, year 30 onwards, very, very slowly. It will take many decades for the problem to become a real problem and for someone to need hearing aids. But, if you... MP3 players are the worst. It's 60% of the total volume for 1 hour. That's not a lot. That's not loud. We usually listen to the music a lot louder than that. So if you usually keep your MP3 player at, let's say, 80 or 90%, the safe listening time would be 15 minutes. And after that, you start damaging your hearing. So clubbing is fine, every once in a while is fine. But if you're a musician, you need to have custom ear protection. If you're a DJ, it's going to be difficult to keep your hearing protected. So, basic stuff like that.
Very good. As a mother of 2 teenagers, I know that they wear their earbuds way more than 15 minutes at a time. So we have a question from Dr. Masella online. She asks, so in the end, at what level of hypoacusia do you suggest to start using hearing aids? At what level are hearing aids beneficial?
It depends. If we're talking about a child, even mild hearing loss, you need to intervene. Even with mild hearing loss, even if it's on one ear, there's a lot of literature that we know for sure that it will affect the child's academic performance and their IQ development. If we're talking about an adult, like someone over 25, let's say, whose brain is ready and has developed all the neural connections, a mild hearing loss is not going to be too much bother. Perhaps in noise environments, yeah, but otherwise, anything from, let's say, above 40 dBHL on your audiogram, like anything worse than that is worth trying a hearing aid out. Or if you have tinnitus, which is ringing in your ears, because that's a symptom of hearing loss, that's a symptom of your brain struggling to hear and straining to hear. And this is a symptom that it is worth to get a hearing aid in.
Thank you. We have another question online from Lada Krylov. She asks, have balance problems also been observed in children with Alport syndrome who wear hearing aids? So can you comment a little bit more about the balance problems you see, and do hearing aids help with that?
Every child with hearing loss is due to have balance problems, because the organ of hearing and the organ of balance are connected. So if the organ of hearing is not functioning properly and you have hearing loss, then the organ of balance will not get the appropriate stimulation from the organ of hearing in order to be able to regulate itself. Because when we are born, we cannot walk. As we grow and as the child reaches a milestone, it learns to walk and balance itself. Children with hearing loss are always late on that milestone. They will walk. When we say walking, we mean on their own, without you holding them, not that, and without the child holding against furniture, etc., etc. On their own, doing their steps. So any child with hearing loss or suboptimal hearing, or even if they have subclinical damage, something that cannot be caught on the audiogram yet, but we can catch it with other testing, they will walk at 14 months, 18 months, 20 months. They will walk. They're not going to be like paralyzed, but they will be late in walking. They won't feel very confident later on to get on their bicycle. They will not feel very confident with sports. I'm not talking about being professional with sports. I'm talking about basic stuff that all children do, or take part in PE like, with other children. Just have that confidence. Children with hearing loss do not have it because their vestibular organs are not regulated properly until you fix hearing loss. And some of them end up developing lower muscle tone. Then you need to have a pediatric physiotherapist involved, etc., etc. So, just fix hearing loss first and then deal with the rest, because the body will adjust itself and just fix itself over time once you intervene.
Right, and we have time for one more question from Dr. Lennon, who's online. If we can get
Hi, Smatya. Nice to see you. So my question is about the children that come first to audiology and have a new diagnosis of sensorineural hearing loss, and how we could improve the pickup of Alport syndrome. So in a family where there isn't a history of Alport syndrome so far, do you think it's feasible for those children to then have that referral so that they have their kidneys checked out?
Just a urine. That comes from, actually, you should be asking Professor Turner, because what I'm doing, that comes from him. That was his suggestion when I was working with him over in Edinburgh. Even now in my private practice, any young person or child or even baby, I know it's not very likely for babies to be diagnosed with Alport syndrome, but I do it, and even if there's a sudden deterioration in hearing loss for a younger person or a child, I always request for a urine test to check for protein and blood in the urine, and then take it from there. There's no harm. It doesn't cost anything. Any pediatrician or any GP will prescribe it. And the parents are always very happy to be thorough.
And do you think you are representative of your colleagues in audiology across the world?
Not really. They are not. It's a very rare syndrome. I was fortunate enough to have Neil Turner in Edinburgh, and we had a great collaboration. And always, I like to study and I like to learn new things. And Neil was always very handy, and all the colleagues at nephrology. Audiologists don't know about it, but it is always very, very handy to have a urine test for any young person with unexplained hearing loss. Even if it's a premature baby and they have high risk factors for hearing loss, you never know. You never know.
Thank you.
All right. Thank you so much for that introduction to hearing loss. I think some of the takeaway points are that early diagnosis and treatment of hearing loss is really important, especially for children. Making sure that kids are getting referred and getting treated is very important. Finding an audiologist in your community who knows about Alport syndrome and knows what to look for. And then also that the technology is getting better every year, just like everything that we do. So the hearing aids that you saw your grandpa wear are not the same ones that we're giving our teenagers these days. So it's my pleasure next to introduce Lisa Bonebrake, the Executive Director of the Alport Syndrome Foundation in the USA, and she is going to introduce our next speaker on hearing.
Thank you, Dr. Rowe. It's an honor to be with everybody here today. And as a mom of a kid with hearing loss, I really appreciate this time spent to hear about new science in hearing loss and know that there are audiologists that understand Alport syndrome and are recommending patients to get tested. I also am honored that Dr. Jeffrey Miner and Dr. Lennon, who you met already today, are going to be the moderators for this session. This next presentation will be given by Dr. Felipe Santos, who is a physician, surgeon, and interim chief of otology and neurotology at Massachusetts Eye and Ear Institute. Dr. Santos is also an assistant professor of otolaryngology, head and neck surgery at Harvard Medical School. Dr. Santos serves as a volunteer advisor to Alport Syndrome Foundation on scientific research related to hearing loss and our rare disease. We approached him in 2021 requesting a proposal to address long-held questions about the root cause of hearing loss and rare disease, and our rare disease, and Dr. Santos graciously agreed. His presentation today is the first time that he's sharing publicly his fascinating findings, and this is going to be a pre-recorded presentation, and then he is hopefully going to be joining us online for some questions moderated by Dr. Lennon and Dr. Miner. So if we can pull up the pre-recorded presentation by Dr. Santos. Thank you.
Good afternoon, and thank you for allowing me to share with you this afternoon our recent findings on our study looking at the otopathology of sensory neural hearing loss in Alport syndrome. My name is Felipe Santos, and I'm an assistant professor in otolaryngology at Harvard Medical School and a clinician scientist at Mass Eye and Ear Infirmary. We'll do a brief overview and go over some of the clinical aspects of hearing loss in Alport syndrome, share with you the findings from our ASF-supported study, and finish up with some conclusions and clinical takeaways. Alport syndrome is a genetic condition that's characterized by kidney disease, hearing loss, and eye abnormalities. First reported in 1927 by Dr. Arthur Cecil Alport in a family with nephritis, deafness, and ocular changes. Mutations in COL4A3, COL4A4, and COL4A5 genes that encode the alpha-3, alpha-4, and alpha-5 chains of the collagen type 4 are responsible for the mechanisms of disease in the kidney. The type 4 collagen is a component of basement membranes, and over 500 different mutations have been described. These alterations are known to affect the mechanisms of disease in the kidney, and one of the questions that we seek to answer is how this affects the inner ear. The gold standard for the diagnosis of Alport syndrome is genetic testing. There is no hearing test that is diagnostic or specific for Alport syndrome. So what do we know about the hearing loss? To begin, I just want to give you a brief overview on how it is that we hear. A sound wave comes into the ear canal, and that in turn vibrates the eardrum. The eardrum puts into motion 3 bones of hearing, known as the malleus, incus, and stapes, which then convert this mechanical energy into a neural signal in the inner ear. On the right, we have a picture of the inner ear, or the cochlea. And in this shot, we're looking at the organ of Corti, which is where the cells responsible for this conversion exist. The primary players here are hair cells that will transduce a mechanical sound wave into a nerve signal along the auditory nerve to the auditory cortex. So when we talk about hearing loss, we can talk about different types of hearing loss. The 2 major categories are conductive hearing loss, which are mechanical losses of hearing. Those can result from things like a hole in the eardrum, fluid behind the eardrum, or some type of problem with the bones of hearing. And then there's sensory neural hearing loss, which refers to some type of pathology that affects the inner ear or the nerve or both. When we look at a hearing test, shown in this diagram, we're recording from quiet to loud the volume at which a patient can hear low to high pitches. In this cartoon, the red line indicates the right ear and the blue line indicates the left ear. And in the low frequencies, this patient has a normal to mild hearing loss that starts to descend to a more moderate to severe hearing loss in the higher frequencies. In Alport syndrome, up to 80% of the hearing losses that have been recorded are primarily high-frequency losses. The progression of hearing loss tends to begin as young as school-age children and progresses over adulthood to more severe, but rarely to profound hearing loss. Profound hearing loss is, however, typically seen in patients with end-stage renal disease. These are some clinical examples of audiograms where you can see that going from low to high frequencies, low volume to high volume, the majority of these audiograms are showing mild to moderate loss in the low frequencies and then a more moderately severe loss in the higher frequencies. In studies that have looked at the correlation of hearing loss with end-stage renal disease and Alport syndrome, what has been seen is that the degree of hearing loss seems to correlate with the degree of kidney disease. That is, patients in end-stage renal disease seem to have a higher degree of hearing loss than in patients that are not exhibiting signs of end-stage renal disease. In order to study the inner ear, we have to look at the organ post-mortem. The inner ear is encased in the hardest bone of the skull and is therefore inaccessible to us in life with current imaging techniques. To do this, we enroll patients through the National Temporal Bone Registry to donate their temporal bone after life. So we've been fortunate to collect a number of temporal bones from patients who have graciously donated their temporal bone during life, including a recent specimen from a family member who was a part of the Alport Syndrome Foundation that we are ready to study and will be included in this study later this month. When a temporal bone is collected at the time of death, it goes through a series of steps in order for us to study it at the microscopic level. We first have to decalcify the bone, and that takes anywhere from 6 to 8 months. We then put it into a block of celluloid, which allows us to cut the temporal bone into very thin sections that can be viewed under the microscope. These thin sections can then be stained, such as with hematoxylin and eosin, or other immunohistochemical stains, depending upon the questions that we're asking. Otopathology refers to the study of pathological changes in the inner ear. So let's begin with a clinical history of the patients that we collected for this study. So shown here is a table listing all the patients that were studied. The ages ranged from 22 weeks to 71 years of age, and it was a predominantly male population. All of the patients had end-stage renal disease, so that's important to keep in mind because our study is really skewed towards one spectrum of the disease, not the entire spectrum of the disease. In terms of the hearing loss, it varied from moderate to severe, and the genetic etiology, when known, was predominantly X-linked. In 2 of the cases, we actually had the genotype, which had been done during life. So what did the hearing loss look like in these patients? So in this graph, we have represented on the y-axis the volume level at which each of the pure tones are being noted by the patient. So color-coded below, each dot represents a different frequency, and each line on the x-axis by age represents what level the patient is hearing their tones at. The red line indicates the cutoff for normal. So in each of the 10 individuals where we had a full set of audiometric data from life, we see that they all present with hearing loss in the higher frequencies. And independent of age, that can manifest at very young age. However, as patients get older, not surprisingly, the degree of hearing loss gets older. It's important to keep in mind that, as with many conditions, the inner ear is susceptible to age-related changes, So changes that we might be seeing in the inner ear are not always explained by a single entity. In other words, a patient could have age-related hearing loss in addition to hearing loss associated with Alport syndrome. The second important measure that we detect or that we measure with audiograms is the word recognition score. The way that test is done is we present a list of words and have the patient repeat them back to us and give them a score of the number that they interpreted correctly as a percentage. So patients can have hearing loss with normal word recognition, which means that by increasing the volume, they'll hear sounds clearly. But patients can also have hearing loss with poor word recognition. So if you were to turn up the volume for those patients, things would still sound very garbled. And so we use a word recognition score of about 50% to indicate or counsel patients onto whether or not they would benefit from a hearing aid. Because if the word recognition is less than 50%, no matter how much you turn up the volume, it's not going to help the patient from a communication perspective because things are going to sound very garbled. But in all the 10 patients that we had the data with the word recognition scores, you can see that their thresholds were all within a aidable range, meaning they would benefit from a hearing aid. What about the otopathology? What does it tell us about the mechanism of the disease? So as this audience knows, type 4 collagen is composed of 6 different alpha chains, which can assemble into different heterotrimers. Loss of one type of type 4 collagen alpha chain can affect the construction of the basement membrane. And so these basement membranes have a very specific distribution in terms of the tissues they affect. The role of basement membranes is varied, and it also depends on the tissue in which the basement membrane lies. So they can provide structural support, polarity to cells attaching to underlying tissues, control of epithelial growth and differentiation. They can mark a path for cell migration or wound repair, and they can also be barriers or serve as barriers to prevent tumor cell invasion. In animal studies of Alport syndrome, where the alpha-3 chain has been knocked out by work by Dr. Kozgrov et al., they found that the alpha-3 chain is present in the inner ear. So it would suggest that similar mechanisms of disease as occurring in the kidney are occurring in the inner ear. In this wild type, you can see that the distribution of the alpha-3 chain is seen in the basal membrane of the organ of Corti, but it has in the knockout, there is no expression of the alpha-3 chain. Meanwhile, in the stria vascularis, which is the blood supply to the inner ear, the distribution is more irregular in the mutant mouse. When we looked at expression of alpha-3 and 5 chains in the human, in the control, we can see that the 3 and alpha-5 subchain are expressed in the spiral ligament and in the basilar membrane. But in 2 of our genetically typed donors, we see that while there is expression in the basilar membrane of the alpha-1 chain, there is no expression in the basilar membrane or in the spiral ligament with the alpha-3 and the alpha-5 chain. Looking at histologic sections of the animal models, what we're looking at here is, again, the organ of Corti, which we showed in an earlier cartoon of the inner ear. And there is a good and reproducible integrity to the cellular structure of the organ of Corti, where the spiral ligament and the stria vascularis and all the cells of the organ of Corti are in relatively normal place compared in the mutant compared to the wild type. At the electron microscopy level in the human, in previous studies, we have found that there is separation of the cells of the organ of Corti from the basilar membrane, where the basement membrane is missing in some groups of these cells. In animals, the structure of the basilar membrane is less organized. And an additional finding in animals is that there is some irregularity here to the basement membrane of the stria vascularis, which was hypothesized as the primary mechanism by which hearing loss occurs. We looked at the microscopic level at all of these specimens and characterized the different structures to see what commonalities they shared compared to controls. Overall, we found that the stria vascularis in all of these specimens was relatively intact, with some minor patchy atrophy that can be seen in a number of conditions associated with sensorineural hearing loss. However, the most consistent findings that we saw in all specimens was the separation of the basilar membrane from the organ of Corti, and a clustering of new cells in a structure called the tunnel of Corti, suggesting that the typical barriers that basement membranes can provide are lost early on during development. The hair cells themselves looked relatively intact. There was no evidence of endolymphatic hydrops, which can be associated with changes with potassium and sodium signaling, as we might expect with pathologies affecting the stria vascularis. And the spiral ganglion cells, which are the auditory nerve fibers, were overall intact. So let's take a look at some of these examples. So on the left side, we have a cross-section of the basilar turn of the organ of Corti. So this is the spiral ligament. This is the organ of Corti here. And here, this is Reiser's membrane. This is the tectorial membrane. And you can see at low magnification, this cluster of cells is all sitting on the basilar membrane. Whereas the finding that we're seeing in Alport syndrome is that these cells have actually separated. So there's this space that we see of separation from the basilar membrane. Here's another higher magnification view where you can see a normal integrity of the organ of Corti along the basilar membrane, good distribution of dendrites, which are the peripheral processes of the auditory nerve fibers, and a relatively intact spiral ligament and stria vascularis. Whereas in this cross-section of a different patient, also with Alport syndrome, we see that there's almost complete separation of the organ of Corti. Again, shown here at a more apical turn, so getting closer to the lower frequencies. And here, in one case, at the very apex of the cochlea. This is a higher magnification view of the cells of the organ of Corti. So this is the tectorial membrane. The inner hair cells sit here, here. You can see the tufts of some of those inner hair cells here. And these cells that the red arrows are pointing towards are sitting within this structure called the tunnel of Corti, which is normally void of cells. And so the fact that this is present in all examples that we have of Alport syndrome suggests that this barrier that the basement membrane may provide is somehow violated, and so it allows for an influx of cells. We have not yet characterized the nature of what type of cells these are. And here, again, we have another view that shows a separation here of the organ of Corti from the basement membrane and that infilling in the tunnel of Corti. And finally, here's a nice mid-medullary section where we see that density of auditory nerve fibers within this structure called the medullus. And so what that tells us is that while the hearing loss may be categorized as a sensory neural hearing loss, referring to the inner ear and the nerve, it's truly just a sensory hearing loss, meaning it's just affecting the inner ear because we're seeing robust populations of spiral ganglion cells in these patients. So the summary of the otopathology that we're seeing in Alport syndrome is that there is a consistent separation of the organ of Corti from the basilar membrane. That was observed in 13 of 15 cases. 2 of the cases where it was not observed are not definitively confirmed to be Alport syndrome in retrospect. And so once we're able to genotype these specimens, we'll be able to confirm that with more certainty. There was infilling of cells into the space of Newell, observed in all cases with separation. And immunohistochemistry of those cases that were genetically confirmed X-linked Alport indicate an absence of the alpha-3 and alpha-5 chain in both the basilar membrane and the spiral ligament. Basement membrane abnormalities are observed in the basilar membrane on electron microscopy, which further confirms our findings. And there is a robust spiral ganglion cell survival observed in both patients with moderate and severe sensory neural hearing loss. Clinical takeaways. Structural changes of the organ of Corti were observed at all ages. Again, this was a cohort of patients that had primarily advanced end-stage renal disease at the time of death. All cases with structural changes in the organ of Corti had hearing levels that ranged from moderate to severe, but all of them had word recognition thresholds that were amenable to amplification with hearing aids. Both moderate and severe hearing loss were observed with robust spiral ganglion cells, which in patients that might have a more advanced hearing loss with poor word recognition would predict benefiting greatly from the use of cochlear implants. So future directions, genotype, phenotype correlations for all of the collected temporal bones. That's a current work in progress. We continue to enroll temporal bone donors with Alport syndrome with all spectrums of disease manifestation. And it will be important to collect longitudinal hearing data to determine if there are modifiable risk factors to prevent the progression of hearing loss, such as exposure to noise. I want to acknowledge once again the Alport Syndrome Foundation for the funding of this project, as well as the National Institute of Deafness and Communication Disorders for supporting our National Temporal Bone Registry. I want to acknowledge all of my collaborators, both at Mass Eye and Ear and at the Brigham and Women Genomics Lab. And finally, encourage you to tell your patients and friends and relatives with Alport syndrome to enroll to donate your temporal bone. That information can be obtained at our website, temporalboneregistry.org. Thank you for your time.
Thank you, Dr. Santos. That was a terrific explanation of the inner ear and the defects in Alport syndrome. Rachel, did you want to ask your question? Live?
Yes, I can ask. I don't. Can we hear Dr. Santos?
Oh, do we have? Oh, we don't have him. Oh.
Had trouble logging in, is what we were trying to get him.
Okay.
Yeah, I think he was on the chat, but I think there's a problem with the audio. My question was about whether this was a clean separation of the cells or splitting of the basement membrane, just as we see with the GBM. And I was curious to know more about those infiltrating cells.
So we have the same question. Yeah, it wasn't clear to me exactly what the basement membrane structural defects are and whether those might be seen to some extent in the mice, because certainly that separation has not been reported by Dominic Cosgrove.
Yeah.
He's focused on the strial capillaries as being impacted by the lack of collagen 4-alpha 3-4-5.
Yeah. I don't know whether our technical team can tell us whether Dr. Santos can hear us and type in a response. He doesn't hear us. Okay, that's fine.
Perhaps we can collect the questions. Would people like to ask the questions and then we can get them to answer them afterwards? Yes, that would.
I think it's important. So we still ask the questions and then we'll feed them to Felipe Santos and get you some answers. All right?
Joy has a question.
Is this working? Okay. I I just wanted to find out if we had more information on the age of onset of hearing loss in Alport syndrome, the typical age of onset.
I found a study recently from some of the doctor's colleagues at Harvard that suggested some degree of hearing loss was reversible, and it was in a mouse POC. So just curious to hear what his thoughts were on that.
My question is, what's the next piece of research? Very interested as to where this is going to lead, because clearly a little bit more work needs to be done. And what does he feel would be the best next stage?
And I was going to ask, has this type of defect been observed in other forms of hearing loss? And could that be informative for what could be done next?
I will say that, in conclusion also, that Dr. Santos did tell us when he gave sort of a preview to Alport Syndrome Foundation about his findings. He did say it did point to two additional tests that we should be encouraging audiologists to take on us on an annual basis when we have our audiograms. There are two additional tests that most audiologists can simply do that would add more information now that we know a little bit more about the root cause of Alport syndrome. This is sort of a groundbreaking new area for research, which he hopes to be a catalyst for, and publish this research and help bring awareness to audiologists about what are the ways that we can collect data to support new potential therapies. Thank you so much. I'm sorry that we couldn't get Dr. Santos online. Thank you.
So we'll proceed with the 12:30 talks on the agenda. I would like to introduce the next two speakers, Marco Mandala, who is an ear, nose, and throat doctor, and Professor Alessandro Ranieri, Professor of Medical Genetics at the University of Siena. Dr. Mandala will give the first 10-minute lecture on CRISPR-Cas9 in an animal model.
Good morning. I'm Professor Mandala of the Otolaryngology Department at the University of Siena, and I would like to thank for the invitation to this really interesting meeting. I would like to thank also the Alport Syndrome Foundation and Susie Gear for supporting this research. The topic of my presentation will be possible application of the CRISPR-Cas9 gene editing therapy for hearing loss in an animal model. The animal model that we used in this research was an Alport X-linked mouse model provided by the group of the Professor Calzat at the University of Bologna. And while it is well known that in humans the changes in collagen type 4 chains at the level of the basal membrane in the cochlea led to mid to high frequency sensorineural hearing loss, in this animal model the phenotype of hearing loss associated to the Alport syndrome is unknown at the present time. Due to that, we had to establish a very comprehensive protocol for assessment of hearing threshold in this animal model. We performed auditory brainstem responses that are auditory potential that arise from the cochlea up to the inferior colliculus at the level of the brainstem. Then we performed electrocochleography, that are potentials that arise from inner and outer hair cells at the level of the cochlea, and we performed also autoacoustic emission to have a better definition of the potential from the outer hair cells, again at the level of the cochlea. We need this really comprehensive protocol in order to have a double check regarding the reliability of our protocol. After a long period of testing, ABR and electrocochleography showed to be the most reliable test to be performed. As you can see in the picture, you can see some samples of ABR recording. The experimental protocol is very simple and non-invasive. We just need 4 subdermal electrodes while the mice is sedated, and we can easily record the potentials in no more than 15 minutes. Here I will present the results of the very first 5 mice that underwent the final protocol, and they were 3 wild-type mice and 2 Alport mice. All were 4 months old of age. At 4 months of age, there were no differences between the wild type and the Alport mice in terms of hearing threshold, as you can see from the graph. But we outlined a really interesting discovery that is related to the changes in hearing threshold of mice after exposure to loud sounds. In particular, we established a protocol where mice were exposed to a loud sounds of 100 dB for 30 minutes, 24 hours before repeating the hearing assessment protocol. And as you can see from the graph on your right, you can see that while wild-type mice didn't suffer any changes in hearing threshold, the 2 Alport mice suffered a worsening of their hearing threshold that went from around 40 dB up to 70 dB. So they experienced a strong worsening of their hearing threshold of around 30 dB. And this is something really interesting that could be extended also to humans. That seems that Alport mice seems more prone to damage related to loud sounds exposure. In conclusion, Alport mice showed similar results in terms of a hearing threshold compared to wild-type mice. But the interesting point is that Alport mice showed a worsening of their hearing threshold after a brief exposition to loud sounds. And this seems a characteristic of X-linked Alport mouse model, and it led to damage of the cochlear structure, and this could be something really new and interesting, and it could also provide us a model for an application of the CRISPR-Cas9 gene editing therapy in the X-linked Alport mouse model. Our sample will enlarge in the coming weeks, since now our protocol is really well established, and the time for performing the experiment is pretty fast and easy right now. After the definition of the audiological phenotype of the X-linked Alport mouse and his susceptibility to loud sounds damage, we plan to apply a preclinical model of gene editing therapy using the CRISPR-Cas9 technique. The treatment will administered in a new way, that is a transtympanic injection that is really minimally invasive, and since we will apply the treatment only to 1 ear, it will let us also to have control on the contralateral ear in the same animal model. And this would be something really interesting from a research point of view, because intratympanic treatment for hearing loss is an emerging technique in humans that is started to be widely used all over the world, and seems to have really nice results. Furthermore, any kind of treatment that is locally administered through a transtympanic injection won't be a kind of systemic treatment, so will only stay in the middle and inner ear of the treated side. Thank you very much for your attention.
Thank you, Dr. Mandala. It's nice to see some data that correlate with Dr. Cosgrove's data showing that noise was required to show a defect in Alport mice. The next talk is by Alessandra Ranieri, also from University of Siena. And we will have questions for both of you after Dr. Ranieri's talk. Which has the same title, I believe.
Good morning. My name is Alessandra Ranieri. I'm Professor of Medical Genetics at University of Siena. I will speak about CRISPR-Cas9 in an animal model. Here is my disclosure as a member of a CAT committee. And I present the gene editing in human Alport fibroblast and podocytes. You can appreciate here the editing in Col4A3 chain using dual plasmid system, a donor reporter's plasmid here, and an autoclaved SP-Cas9 plasmid. When both plasmids are transfected in the same cells, the cells become green, and we have obtained by this system a correction of about 40% of alleles, with less than 5% of incidental alleles not desirable. Similar data we have on Col4A5 gene with the same system with dual plasmids, and the correction in this case it's up to 58% of edited alleles. with again about 5% of the INSDEL. So then we have adapted the system for the correction of a mouse model called G5X with a stop mutation in the glycine 5 of the chain. So the system is similar with single guide RNA. You can appreciate here the PAM, the mutated nucleotide, here the first amino acid methionine, and we, as you can appreciate, there are no potential other matching loci in the genome. We have also assessed the biodistribution and decided that AAV9 is better for the biodistribution for kidney in respect, for example, to AAV2. You can appreciate here the localization in the periglomerular region, and the signal increases with the time, and you can appreciate here the prolonged infection from 72 hours to 24 days, which is better for having more infected glomeruli. So then we are now ready for the delivery in vitro through the AAV9 dual systems. The G5X mouse model is a very well-known model and characterized for several systems, including the immune system, the vision eye, and of course the renal urinary system, but is not characterized by the auditory system. It is not characterized in the auditory system. So now I leave the podium to Professor Marco Mandala, who will speak about this kind of characterization of the auditory system and how this can help the model, the correction, and to reach a therapy for Alport syndrome. Thank you so much.
So thank you, Dr. Ranieri, who is trying to get online with us so she can address. We have Sir.
Yeah, hi, do you hear me? Obviously, I'm not Professor Ranieri, but Professor Ranieri has some troubles with their connection because now she's in Trieste for attending the National Human Genetics Congress, but there is some troubles about the internet Wi-Fi connection and she's unable to complete the walkthrough and she cannot attend now. So I'm at her place to reply to your question.
Okay, thank you. Do we have any questions from the live audience?
Thank you for the talks. The question is for the designate for Professor Ranieri regarding gene editing. So was there any off-target effects observed, and what's the concern, if any, regarding using gene editing and unexpected effects?
Yeah, sure. Obviously, the off-targets, as you know, about the gene editing and in general the CRISPR are the main scarecrow of the system, not only for what observed in vitro, but also for in vivo. Effectively, during the years, different assays have been set up to detect and to define the precise off-target of the system. The most known is the GuideSeq, and we started to perform the GuideSeq to detect the in vitro off-target for the alpha-5 and the alpha-3 mutation corrected, and also this is our idea to perform for detect possible off-target for the mouse single guide RNA designed. However, it's important to say that our single-guide RNA are designed and tested for the bioinformatic bioprediction for the off-targets. The mouse, which is, as you see from the presentation, indeed there is one single-guide RNA that do not have off-target for bioprediction because it matches only for the wild type allele. So what the slide means that our single guide RNA can match one mismatch the wild type allele. But considering that we use the mouse, which is hemizygous for the mutation, these mice do not have the wild type allele. So for this means that we do not have off-target potential site for this single guide RNA. But the test for detect the off-target matched for the single guide RNA that we used are ongoing, and we are set the best strategy, the guide sec or before obviously to go in deep.
So we have another question from the room. Joy?
Hi, this question is for Dr. Mandala. I noticed that you did the testing on the mice after noise exposure 24 hours later. Did you also go back and retest them, say, 2 weeks later to see if that was a permanent level of hearing loss?
Yeah. That's a really good question. No, they are routinely monitored for the assessment. So they are performing a complete protocol, including ABR and electrocochleography once a week, because you have to prove that the effect is it will stay there over time. Yeah, it seems like that. The number of mice that we enroll right now, it's very small, so it's hard to have some conclusion right now. But I agree. No, we have to monitor very closely in this experiment all the mice. And another point, if I can add something that could be very interesting for this kind of transtympanic treatment with the gene editing therapy, is that when you administer something through the tympanic membrane, you don't get any diffusion of the drugs from a systemic point of view. It won't go in the blood, so you have a passage of the treatment through the perilymphatic space and then to the endolymphatic space. That is a really close compartment, as you saw also from previous presentation. So that could be really interesting also from an experimental point of view. And it's totally non-invasive, and it's an outpatient procedure, so it's really easy to perform. Thank you.
I had a question for you as well, Marco. You showed that the mice were 4 months old, so I presume they're not the 129 strain that Dr. Cosgrove had used. Which strain were you using for your...
Sorry?
The mice you used were 4 months old, is that correct?
Yeah.
ABRs. So those could not be the 129 strain. Which strain background were you using?
Well, I'm not very expert regarding the animal model. I can provide you the answer asking for the group of Professor Calzat, because I'm an ENT. I'm not a really expert regarding the animal model, but I can email easily the answer. It's not my job.
Sure, understood. Thanks. Any other questions from the room? I did want to ask about the AAV9 data that were shown. So have you looked at which cells in the glomerulus are actually being targeted and expressing the fluorescent protein? What percent are podocytes? What percent mesangial cells?
Yeah. This experiment exactly to detect which cells are infected is ongoing in this moment, because we appreciated that the prolonged infection and increases dosage of the AAV give us the chance to see a specific and precise periglomerular localization, as you see from the slide. So we have a co-staining performed with laminin and with nephrin that give us the chance to appreciate precisely the internal circumvolution of the glomeruli and the internal cells. And we appreciate this half-moon shape localized exactly near the glomerulus. Our idea is that we sacrifice the first mice at 24 days. So we want to observe that a prolonged infection can allow the passage of the virus inside the glomeruli. And we performed also continuous and other immunofluorescence to detect the cells that are infected in this moment, the periglomerular cells, so mesangial or PEC cells or some other ones. So these experiments are ongoing in these days.
Okay, thank you. And there are a couple of questions online I wanted to bring up. One, a quick throwback to Dr. Santos's lecture. There was a comment from Dr. Michael Angraten about a potential problem between the length of time between when the patient died and when the temporal bone was obtained and fixed properly. So there could be an issue with that. She also wonders whether cochleograms have been obtained from the noise-exposed mice. A question for Marco.
Yeah. They are obtained from all mice in that are submitted to the protocol. Yeah, okay. Obviously. And we just briefly present most of the ABR results, but you can have some slightly differences in between the threshold if you're looking at ABR outcomes versus cochleography outcomes. Cochleography is a more precise technique to identify the threshold. So often you get, but that works the same also in humans. Often you can get a threshold that is better of around 10 to 20 dB with the ECOG. The key point is that you can clearly outline also the site of the lesion. So this is very interesting from an experimental point of view. But obviously, yes. Thank you.
Okay, thank you. And a final question from Rosa Tora for Alessandra. What was causing the interstitial nephritis in the mice?
Sorry, I don't listen very well to the question. Can you repeat, please?
Yes. What was causing the interstitial nephritis in the kidneys that were shown?
In the mice that we are using in this moment, I suppose. Yes, for what concern the mice that we used, obviously the part related to the urinary kidney system is well characterized. So there is obviously an interstitial nephritis caused by immune system infiltration, thanks to the increasing. Obviously, there is a need, and it's necessary to make a precise consideration. The mice in this model present high level of proteinuria that is a particular level. What I mean is that all the mice present physiological excretion of proteinuria. So the 485 mice, we can define the start and the onset of the disease when the level of proteinuria are higher than the baseline. And this increasing of proteinuria trigger an activation of immune system cascade that induce the interstitial nephritis, that induce a widespread inflammation and a massive invasion of immune cell system inside the kidney that starts the trigger of the disease in terms of interstitial nephritis, glomerulonephritis, dilatation of tubules, and obviously all the characteristics that start the Alport syndrome conclamate condition that we can appreciate.
Mm-hmm. Including filtered albumin, probably.
Yeah.
And Rachel, I'm not sure if you're online with us, but did you have any comments? Maybe we don't have. We do.
I haven't. No, I've been listening intently. That's all fascinating.
Okay, then. Thanks to the speakers. I will turn the floor over to Susie for some final words before lunch.
Excellent. I just want to thank all the speakers that we've had this morning online, and also for your wonderful attention in the room. It's fantastic to see so many people here, so thank you very much. One of our speakers is not 100% this afternoon, so we're going to have a shortened talk, so which means we can extend the lunch time. So you've basically got a full hour, and online we're going to put a message to all our online participants that we're due back in an hour's time. All right, so I hope that's a really positive thing, and I'm just so grateful to everybody for keeping us on time. Thank you so much to all our moderators.